Seeking the blessings of His Holiness Jagadguru Shri Deshikendra Mahaswamiji, I, Dr. Paras, Faculty of Dentistry, Department of Conservative Dentistry and Endodontics, JSS Dental College and Hospital, JSS Academy of Higher Education and Research, Mysuru, Karnataka, welcome you to today's webinar. Thank you for joining us for today's webinar. The topic of today's presentation is Periodontitis and Systemic Impairments in Patients with Brain Injury, presented by Dr. Mohit Kothari. Before we get started, I would like to welcome Dr. Manjunatha B., Registrar, JSS Academy of Higher Education and Research, Dr. Ravindra, Principal, JSS Dental College and Hospital, Dr. Deepika, HOD, Department of Periodontics, Dr. Sheila, Professor, Department of Periodontics, JSS Dental College and Hospital, and I would like also to welcome my dear friend, Dr. Mohit Kothari, the speaker for today's webinar. I now request Dr. Ravindra to introduce our guest of honor, Dr. Manjunatha B.
Thank you, Dr. Paras. Good afternoon to one and all. It's a great pleasure to introduce our beloved Registrar, Dr. Manjunatha B., JSS AHR, Mysuru. He has completed his MBBS degree from JSS Medical College in the year 1994 and MD Forensic Science and Toxicology from JNMC Belagaum in the year 2000. And he has served in various capacities, that is as assistant professor, associate professor, and vice principal and chief warden, and as a registrar. And he is a confident and enthusiastic leader of JSS AHR. He believes in the importance of communication and build a positive relationship with the staffs and students. He always works towards the goal and mission of the organization. He has many national and international publications to his credit. With this brief introduction, I welcome him once again. Thank you.
Thank you, sir. Let us now begin with the webinar inauguration. I request Dr. Manjunatha B. to kindly give the opening remarks and declare the webinar open. Sir, over to you. Sir.
Thank you, Paras. Thank you, Dr. Ravindra, for your nice introduction. I think seeking the blessings of His Holiness, I think it is a privilege to be a part of this webinar. Recently, we were having a meeting regarding AI, artificial intelligence, and healthcare. So many of them got involved. So when I saw the topic, I was very excited. So recently, our Pro Chancellor shared a video where Sundar Pichai, the CEO of Google, speaks about Google AI, particularly in relation when he cites an example of diabetic retinopathy, where the retinal vessels, you can predict the future, where the patient in a few years where he is going to land up, particularly with regard to stroke, cardiac ailment, etc. etc. I think same thing, I think we can work with Dr. Mohit regarding his field of work, periodontitis and systemic impairments, whether it is brain injury or other areas also. So that's what flashed me immediately. So one of our colleagues from JSS Hospital is working in the team, in fact, other than one. I think we can also involve Dr. Mohit also there, because his expertise will help us to go a long way in that field also. This is what immediately flashed me. I think periodontitis so far is considered as any other health issue, but Dr. Mohit's presentation will throw a new light here, bridging the gap between medicine and dentistry, as he always been doing, and is working in a medical hospital there, where periodontal examination can be the future prognostic tool for various systemic illnesses. So this is where this the uniqueness of this webinar lies. So without wasting much time or without spending more time, I think we just go over to Dr. Mohit, and we are all interested to hear from you. Thank you.
Thank you. Thank you, sir.
Thank you, sir, for the nice experience and virtual inauguration. Right now, we have more than 250 participants attending the webinar. For those of you joining now, I welcome you all. If you have any questions during your presentation, please type them in the question box in your control panel. We will bring them up at the end of the presentation. I now request Dr. Sheila to introduce our speaker of the day, Dr. Mohit.
Today I am very privileged to introduce an eminent speaker, Dr. Mohit Kothari, who has done his BDS from Rajiv Gandhi University of Health Sciences, India, and he has done his PhD degree in Rehabilitation from AU, Denmark, as well as done his master's in swallowing disorders from UAB, Spain. So not only is this the not only is this, he is also right now working in as an associate professor at Hamel Neuro Rehabilitation Center, Aarhus University, Denmark. Also, he is the associate professor in the Department of Clinical Medicine, AU, Denmark. And we are also glad to have him as an adjunct associate professor at JSS Academy of Higher Education and Research here. And his area of interest is mainly swallowing disorders and rehabilitation, special care dentistry, bruxism, orofacial dysfunctions and rehabilitation, sleep apnea, and motor learning, as well as he is a clinical consultant for management for dysphagia and oral health in patients with brain health. Now coming to his academic expertise, he is a certified university level teacher as well as an international faculty speaker and a course co-coordinator for master class on swallowing disorders at UAB, Spain, and a teacher at neurology residency program in Denmark. Not only that, he has supervised 3 postdoctoral fellows and more than 5 international PhD students. He has 3 master's students and 3 visiting researchers in foundation, and is in the process of helps in processing and scientific writing of the research projects. Right now, he has 3 international PhD students, and he is involved in clinical theoretical teaching as well as webinars to the health professionals at Central Denmark Region Hospital. He has contributed more than 35 peer-reviewed international journals and a book chapter in a short span of 10 years. And I would like to add on here itself that being an adjunct faculty, he has contributed to our university also 9 publications, of which 7 are in press, are published, and 2 are in press. And we acknowledge him, and that too he is contributed to high impact journals, and which is having an impact factor of 3 to 4. So this is a great thing, and we really want to acknowledge him for this. And also he has 450 citations with a H index of 13. And he has been to many of the international conferences and contributed as a keynote speaker, invited speaker and guest speaker, as well as he is a reviewer for various neuroscience journals and European Journal of Oral Sciences and Journal of Oral Rehabilitation, as well as he has collaborated with various international universities like Western Ontario University, Canada, Buffalo University, and the university in Japan. In addition to that, he has got many grants as well as an investigator grant to develop an oral health assessment tool and treatment plan, as well as he has got an excellent achievement award, coveted folk Nielsen Award, and travel grant to conduct clinical research at University of Western Ontario, Canada. So we are very happy that Dr. Mohit, who is an adjunct faculty of JSS AHR, has spared his valuable time to enlighten us on the topic periodontitis and systemic impairment in patients with brain injury. This is an area which most of us have not explored, and this will be an interesting topic which would help us to bring out more collaborations and research. And once again, I also take this opportunity to thank Paras, Dr. Paras, whose close friend is Dr. Mohit, who has kindly accepted this invitation. And so I hand over to you, Dr. Mohit, for your webinar. We are impatiently waiting for it. Thank you.
Thank you.
Dr. Mohit, you can start.
Yeah, thank you so much for such a detailed and a nice introduction about myself. I was not aware that I was doing such a lot of things actually. So thank you for brushing it up for me. I think I will not take more time and then we can start with the presentation if Dr. Paris is fine with that. Should we?
Yes, you can start sharing your
Sure.
slides.
So yeah, perfect. Let me know once you see the screen so then I can go forward with that way. You all able to see my screen?
Yes.
Okay. So let's start actually. As you all know, the topic periodontitis and systemic impairments in patients with brain injury. So that's the main reason why we are here today. I have already been introduced pretty much in detail, but I just want to let you know in a brief overview that I did my graduation in dentistry from Davangere, Bapuji Dental College, and I have a specialty in swelling disorders, which is a kind of a master specialty that is done from the European universities in Barcelona. And I did my PhD actually in oral neuroscience. So basically, I was trying to make all the correlations, what really happens in the oral cavity with the orofacial dysfunctions, and how does that impact at the brain level. So that was my whole PhD about. So I was connecting the dots between the brain and the orofacial dysfunctions. Right now, I'm appointed as an associate professor at Aarhus University. And from last year, I got this wonderful opportunity to be an adjunct faculty at JSS University, Mysuru. So I'm really grateful and thankful about that as well. As I said you that I work in a neuro rehab hospital, which is basically one of the biggest hospital related to neuro rehabilitations in Denmark, and which is affiliated to Aarhus University. Most of my current projects has a principle of bench to bedside approach. That means that we do a lot of different kind of developing a different tools and different treatment plans that we test on the laboratory level first, and then we take towards the validation and specificity studies. And finally, the main aim is to apply that into the clinic. So that's a whole process that why we go with the step-by-step process that finally it reaches to the patients with a goal of their improvement in quality of life. Most of our projects that is basically dependent on the multidisciplinary team. Here in Aarhus University in Hamel Neuro Center, the main principle is that, okay, being a medical doctor or being a dentist or being any other profession, so you know your field, but in order to complement and make it much better to a diagnostic level or to the treatment plan, there is a special way of putting forward this process, which is called as multidisciplinary team. So here we have everyday day-to-day cooperations and collaborations with dentists, nurses, occupational therapists, and neurologists, which comes together. We have once a week meeting here, in which any new patients comes, then we discuss, okay, what's the diagnosis, what's the new treatment plan, how we can make the patient's life much better in terms of giving rehabilitation to them. So it's a kind of a collective effort rather than only one single effort from one kind of a profession. And that's why this multidisciplinary team becomes a really logical point in the hospital setting. And now I'm just talking about the dysphagia and orofacial health. Dysphagia is one of the very prevalent conditions which we usually ignore in a lot of patients and even in our elderly population. For example, our parents who are much elder. When we eat food with them, you can see that they compensate and they try to maneuver the food in a way that we can eat easily, but they struggle to do that. So that's why this multidisciplinary approach is a very important aspect. And every professions, from dietitian, from the kitchen, from the nurses to dentists, everyone role is very, very vital in order to really diagnose properly and to make a proper rehabilitation plan. And that's why we work on this principle of called as multidisciplinary team. And how does it really benefits? I said you that we as a single profession, as a dentist, we can see only the view, what we can see, which is a photographer here. But when we have all surroundings giving us much better ideas, then we can really find out the right diagnosis and thereafter the treatment plan, which is a penguin, a small penguin over here. So we need to believe that it's not only one profession who can give us all the answers, but we need to find the answers from different professions, from different point of views also. And that's why it's very important to go forward that way. Just a very brief explanation what exactly I have been doing it from last 10 years before I landed to Denmark, and how my research flows in this last 10 years. And this 10 years sounds like a lot of a long process and period, but you will realize that how research complements together with the academics here to take these tools and finally apply into the clinics. I said you that my main specialty is swelling disorders, so I see a lot of swelling disorders patients. But being a dentist, we should not ignore that this is also a very prevalent finding. And in my future slides, you will see that how swelling disorders and oral health impacts together the patient's quality of life. As you know, I'm a dentist, so my lot of projects actually runs on a special care dentistry. And when I say special care dentistry, that means focusing on oral health, orofacial health, how we can improve the patient's quality of life, and basically rehabilitation plan. My lot of projects has been dealing with how to connect the dots between the oral cavity and the orofacial dysfunctions to the brain level. So I have been giving my lot of time in brain imaging devices like fMRI, like TMS, transcranial magnetic simulations, to learn the morphology, the kind of a physiology that every disease has a connection with the brain. That's my another topic, which is called as Bruxism. I mean, we see a lot of patients in our dental clinic itself that they come with a complaint of grinding of the teeth, and then we need to find a proper and thorough solutions and suggestions for that. So I was operationally in making a device for that also, which you will see in the next slide. Other than that, orofacial dysfunctions, which we know that, okay, this is one of the major topic has been ignored a lot. For example, like perceptual distortions, neuralgia, and all like that. It sounds a bit complicated, but if we really follow the principles and the mechanism behind it, then we can really reach to the right diagnosis and thereafter the right treatment plan. It's very important to know that we always jump to the treatment plan, but we should know that diagnosis is as much important as important as the treatment plan. Have been dealing from last 5 years with sleep apnea patients also, and a lot of people say, okay, this is a kind of an ENT job, then why are you as a being a dentist are involved in this one? But if you see that there are a lot of devices which have a dental origin, for example, mandibular advancement therapies. So this can help the patients to sleep, have a sound sleep in the night, and without having obstruction in the breathing. So as I said to you that most of the projects are from bench to bedside approach, in which we develop this kind of a tongue drive system. It's a kind of a device in which the patients can have a control of the whole computer. And our whole idea was that the patients with the tongue dysfunctions, they can play a computer game just by moving the tongue inside the oral cavity. That gives them the skill training, and this is a kind of a rehabilitation program for them, which helps them improve their motor abilities, their cognitive abilities actually. As I said to you before, that this is a small device which is called as a grind care. This has been developed in our lab. It took 10 years of a process. So the version was quite bulky, and it was very sturdy. But during a course of 10 years actually, we have made this small device in which you can attach the device to the temporalis muscle, which this muscle records the jaw muscle activity, which is therefore a grinding activity called as Bruxism. And this device also has a rehabilitation plan. So it also provides you a treatment plan. For example, if any patient is bruxing more than 20 grinds per hour, so it sends an electrical impulse to the masseter muscles, to the temporalis muscles, to calm down, and then generate activity of the muscles like that the patient's Bruxism activities goes down. So this is how this particular device works, and this is now available in the market, and so people can buy and they can use for their Bruxism habits. This is another thing which I told you, that the brain imaging things, that how you can connect the whole oral cavity to the brain stuff and look on different kind of deformities that's happening in the oral cavity. As I explained to you about the sleep apnea actually, so this is the device that right now we are running nationwide randomized controlled trial studies in which we are giving these devices to the patients with sleep apnea. Patients from mild to moderate sleep apnea, they wear this device in the nights, and this helps the mandible to advance forward, and which consequently helps the patients to open their lung pipe or the trachea. So in the night, they can sleep properly without having an obstruction in the breathing. So this is right now, this is an ongoing project which is in which we are running on sleep apnea patients. And other than that, I have been doing a lot of other swallowing rehabilitations programs also here. So I would not go much in detail about that. And then let's start today's topic for which we are here today. Acquired brain injury. This is a kind of a type of brain damage that usually happens after birth. Broadly, we can divide ABI into two different categories, which is traumatic brain injury. For example, like people having road traffic accidents and any kind of a trauma that leads to a traumatic brain injury, and that makes a lot of changes in your at your brain. For example, like you lose the motor abilities or the cognitive abilities. But most of the patients that are having an internal trauma, for example, like blood clots, and the most common one which we see is the stroke. So most of the stroke patients come under the acquired brain injury principles over here because of cerebrovascular disorders, cardiovascular disorders, and because of that, there's a clot in the capillaries, and that lead as an obstruction to reach the blood supply to the brain, and then the stroke happens. But while this phenomena happens, there is there is a motor and cognitive compromise complications that happens after the brain injury, and especially 80% of the stroke populations, they are affected by the activity of daily living just because of the motor and cognitive deformities. And why this motor and cognitive deformities are important as a point of a dentist? Because of this impairment, there are a lot of functional limitations that's happening around all over the muscles, which is in our body, but it also focuses on the orofacial muscles and as well as the dysphagia, basically, which results in orofacial dysfunctions and dysphagia. Here you will see a chart. Actually, what I'm trying to explain here is that, you know, food is our a main source of a meeting criteria. Actually, whenever we go out with our parents or with our friends or families, what we do is that we order the foods. That's our kind of a lifestyle that we share our social bonding together with the food. And this study was done back in 2018 with the data collected from the last 5 years. It shows that on average, how every single nationality uses their time in the 24 hours, spending the time together with the food. And why food is important, because that also gives you the social life, the social activities around it. And you can see that Denmark, average Dane spend almost 2 hours in the whole 24 hours spending their time eating the food. So you can see that how food is revolving around our social activities and our quality of life. And even in India, the average time that every Indian uses to eat the food, not to prepare the food. For sure, we Indians take a lot of time to prepare the food, but it's also important to enjoy the food. And each individual Indian spend almost 1 hour and 20 minutes with the food. So food is a really important factor over here. And that's why the dysphagia comes in the picture. So any difficulty in swallowing, which is a common disorder, and it's a very prevalent condition in 78% of the ABA populations, and majority of them is the stroke populations. Dysphagia, the difficulty in swallowing, leads to feeding problems and malnutrition. And it has been shown in our previous studies also that dysphagia, together with the poor oral health, complicates the situations much worse. And because of the oral cavity, it has a lot of oral pathogens that leads to the aspiration. And because you cannot swallow, so that oral pathogens, instead of going to the stomach, it reaches to the lungs actually, and that leads to the life-threatening pneumonia. So pneumonia is one of the severe complications that happens because of the combination of poor oral health and dysphagia. And that's how the dentist role is much vital and much more important when we look on the bigger picture here. And for sure, if you cannot eat the food, it pushes the individuals away from the satiety and the pleasure that you cannot go with. It leads to the social isolation. And now coming to our topic, that why I'm trying to relate this oral health and the periodontitis to the dysphagia and consequently to the brain injury. What the literature has shown so far is that periodontitis and various other systemic inflammatory conditions such as like stroke or diabetes, they have several factors which are very common, including an altered host immune response and a chronic and persistent low-grade inflammation. So what I'm trying to say here is that any person who is having a periodontitis, they always have some kind of a low grade of inflammations, and which is also seen in systemic disorders like this, like diabetes or a stroke population. And the literature also shows that the brain injury and the periodontitis, they share a common etiological backgrounds. For example, like the smoking habits and different risk factors. So there is some kind of a connect between periodontitis and different systemic disorders, which has to be think properly and has to be taken seriously into the consideration. And previous studies have also explored association between ABI and oral health indicators. But what we have seen is that all the models, they have used a simple analytical approach. What they try to do is that, okay, this person has a periodontitis and also has a stroke. And they try to make a correlation with a very simple analytical approach. But we need to really think about that. It's not only a brain injury, stroke, and periodontitis, but there are a lot of other risk factors, for example, like a smoking habit, if the patient is visiting a dentist frequently or not. And there are a lot of other environmental factors which also contributes together. So we have to think as a bigger picture here, and in which what we try to do is that we introduced a new model which is called as factor analysis approach. In this, we try to take all the different aspects of the body, for example, environmental factors, the social behavioral factors, their medical conditions, and then we try to put in a single model together, in which the model works on its own, and then it tries to correlate different findings together. For example, the motor disabilities and the cognitive disabilities, and then it tries to correlate. Does it have any correlation with a mild periodontitis, for example, or a severe periodontitis? This might sound bit complicated right now, but I will flow with the presentation, and then you will get a real picture about it. So a suitable approach to deal with this data in factor analysis may be a method to reduce the data following the joint variation of several observed variables. As I said, smoking, diabetes, and dysphagia, and all other factors like motor deformities and cognitive deformities. So given the similar complexities of ABI and periodontitis, when we look on the micro level, they both shows very much similarities between. So one may speculate that whether factor analysis might be used to better describe the association between ABI and periodontitis. So this is how this particular study led us to think in that direction. So the main aim of the study was to investigate the association between the clinical oral health parameters and systemic impairments in individuals with ABI. Before I go deep into the study, I just want to let you know that this study is a part of a very big project which is called as OHET project, in which our idea was to develop an oral health tool, not only the assessment tool but also the treatment plan, which is called as OHET. So for the nurses. But during this course, we also did this study. So this is just a small slice of our entire big project, actually. In which we took 132 individuals with a brain injury. They were screened, and after inclusion and exclusion criteria, there were 90 ABI individuals which were clinically examined. What the procedures that were screened on this particular patient was that we took their dental and social behavioral histories like age, gender, smoking habits, brushing habits, and their dental appointment frequencies, how many times they have been visiting the dentist in the last 1 year, and all like that. Other than that, we also had we took a medical history, how long the brain injury happened, the onset of brain injury, the onset of pneumonia, the length of stay in acute care, because all these factors really makes a lot of difference when you try to make a factor analysis approach, that which factor is much more responsible or significant in order to know this kind of a correlation. And we also took a lot of motor and cognitive deficits parameters. So for example, when the patient is admitted to the rehab center, there are different kind of a brain injury scales that has been taken. And from that, we took all the motor and the cognitive scores actually in order to do a correlation. And a trained dentist also did a full mouth clinical examination in which we took a University of North Carolina probe, and it was used to, this full mouth clinical examination was done on 6 sides of each tooth. So what we did is that 6 sides of each tooth into 28 tooths. So we did a 168 sides parameter analysis over here. And then we were recording their ongoing destructive periodontal diseases by clinical attachment loss, by probing depth, and as well as the presence of plaque, calculus, and bleeding on probing. So this was a thorough, detailed examination, because whenever you're trying to develop a tool or whenever you're trying to make a prognostic tool, you need to take all as a total together rather than just having one single site. So we took 168 site in the whole oral cavity before we can reach to any conclusion. What we find from the study was that, as I said, there were 90 individuals, and most of them were 71% was a stroke population, and 60% of this particular people who were admitted because of the brain injury, 60% were current or the former smokers. So you can see that how smoking really impacts this kind of a lifestyle. And 50% were having issues with the swallowing disorders. As I said, 71% were a stroke population. Moving to the detailed clinical oral examination results here, what we find out that each patient who was admitted, there were 2 tooths out of the whole 28 tooth that were decayed. So they had some kind of a caries, and there were 4.5 teeth which were filled actually. So you can see that these patients were really having a lot of oral health issues here. And 4.9 tooth, so basically it was around 5 tooth each individual that was extracted actually. So you can see that how oral health parameters really make a difference. For example, if you don't have a tooth, that means you cannot chew properly, you cannot masticate properly, and then you might have swallowing problems. And in the same way, if you don't keep your oral hygiene proper, there are a lot of cavities. And this is just not related to the local factors, which is a dental caries, but also it creates a lot of oral pathogens, which finally lands in your lungs and causing pneumonia. So these are the very small factors, but are very significant contributing factors that can lead to pneumonia. So we should not ignore this oral health findings actually, that why this is very important even in the systemic disorders. There were almost 75% if we include moderate and severe plaque together, that almost 75% of the populations who were admitted in the neuro rehab center had a mild to moderate dental plaque accumulation. And it was an astonishing finding for us that 74% of the entire population were having a stage 3 periodontitis. The stage 3 is basically a most severe kind of a periodontitis. So it says a lot of story here that it's not a kind of an only acute phenomena, because these patients had a very compromised lifestyle. For example, like they have a poor socioeconomic status, they have a poor education, quality of life, they might be smokers. So this also gives us a story that has to run before the injury happens actually. So what I'm trying to say here is that if we really target this population, promote this population far before in the youth age, by just giving a small periodontal examinations, this oral health promotions can help to reduce different kind of activities of daily living. And finally, they will not end up in the hospital actually. So from this factor analysis approach, what we really find out is that we try to divide the whole periodontitis into 2 different parts, which was moderate periodontitis and severe periodontitis. So moderate periodontitis was much more associated with the motor functions, and it makes sense because moderate periodontitis is a disorder that happens within the last 1 to 3 months actually. It's not active, it's not a chronic phenomena. Moderate periodontitis compared to severe periodontitis is much more an acute phenomena, and that happens due to the accumulation of dental plaque and bleeding on probing, and on top of that this traumatic brain injury which leads to the motor function. So here we can see that there was a clear-cut correlation between the motor functions and the moderate periodontitis, and even the dysphagia and the pneumonia on the hospitalization was much more significantly correlated with a moderate periodontitis, which gives us a story that, okay, this is a very acute phenomena, and this is happening because of the hospitalization effect. So what my proposal here is that do moderate periodontitis relates to the acute phenomena. So basically an hospitalization effect. So whenever the patient is in the hospital bed, he is much more cognitively disabled, motorily disabled, he cannot move his hands and legs like that. And that's why the oral health gets more deteriorated, because he cannot take care of the oral health. And that's why the moderate periodontitis has much more correlation with the acute phenomena of a stroke. And then what we also did in this factor analysis approach is that, before going to the severe periodontitis, I just want to brush up that what we find out with the moderate periodontitis. So moderate periodontitis, consequences of plaque accumulation was strongly associated with motor domain, dysphagia, dependency on feeding tube, and onset of pneumonia, which all are basically an acute hospitalization effect. And in a hospital setting, these clinical parameters are relevant indicators for monitoring the level and quality of the oral care delivered by the hospital staff, as poor oral hygiene is directly related to the dental biofilm, which is plaque accumulated over teeth and presence of bleeding on probing. which can lead to the aspiration of oral pathogen and finally can lead to the life-threatening conditions like pneumonia. So we have to think that oral health can be divided into two different phenomena. One which is happening due to the hospitalization effect. So here the nurses makes a bigger role. Being a dentist, we don't have an opportunity that we can be sitting in the each wards, but nurses are the frontline workers. They are the main persons who are dealing with the oral health of their everyday life of the patients. So if we teach them, if we educate them, then it can be a very easy process to remove the plaque. And when we can remove the plaque, we can also remove the threat of aspiration of oral pathogens. So that's why this acute phenomena is also very important to understand, that how the oral cavity can be kept clean, at least to avoid the acute hospitalization effect. And now moving to the severe periodontitis, as I said you before, that in this factor analysis approach, we try to divide the whole patient group into the moderate and severe periodontitis. So when we look on the data on the severe periodontitis, it was much more correlated with the cognitive functions actually. So the moderate was much more correlated with the motor functions, which is much more like an acute phenomena. But cognitive functions are like, are much more of a chronic phenomena. So it gives us a story that something was already happening before in that person's life, which is a more chronic phenomena. And that's why the severe periodontitis, which cannot happen in a 1 week or a 1 or 2 months, this severe periodontitis was the part of that patient's life beforehand because of his poor socioeconomic status, his education level, the smoking habits, and all other like that. So we really need to think about that severe periodontitis is not a phenomenon that's happening just because the patient is admitted in the hospital. He is carrying this bag from his earlier lifestyle. And this is what it also shows here, that severe periodontitis has a significant correlation with the cognitive functions and as well as to the dental visits. So less the persons had a less dental visits, actually, they had a more severe periodontitis. And it says the story that while we need to go and frequently visit the dentist at least every 6 months, in order to get a checkup proper. And then if there are some deformities, if you have a periodontal issues, then that can be solved during the due course, because it also gives you a bigger picture here that it's not only the oral cavity, but your whole body. If your oral cavity is sound, your general body is also sound. This is the whole takeaway home message behind this particular slide. So as I said you before, that do severe periodontitis relate to the chronic phenomena of stroke? Can we really think this as a prognostic model in a whole general population, where we can check the patients with their periodontal conditions in their early stages of life, and if they have some kind of a periodontal conditions, can we really promote them, educate them to avoid this kind of a lifestyle? So what we really concluded from this particular severe periodontal factor analysis approach is that plaque and bleeding, which is mainly results from the poor oral hygiene, which is a hospitalization effect, but severe periodontitis results from an altered host immune response, and that may not be directly related with only plaque accumulated over teeth. So this is what I tried to say, that it has a long history of their social behavioral history, which is leading to the severe periodontitis and consequently maybe acquired brain injury. There has been a strong association found between severe periodontitis and cognitive domain in our study as well. And there has been a lot of systematic reviews which has reported the same kind of a probability of developing cognitive impairment with those people had a periodontitis. So ABI and severe periodontitis are a chronic cumulative conditions with easily recognized indicators of past disease experience. So what I'm trying to propose here is that, can we really take this model, periodontitis or a periodontal clinical examination, as a prognostic model in order to diagnose systemic diseases much earlier in the stage of the patient's life? For example, the stroke happens usually at the elderly stage. But if we develop this kind of a periodontal examination model in the early lifestyle of the patients, for example, like in 20 years, 25 years, 30 years of age of our patients, if we do that kind of examination, and if those patients suffering from periodontal diseases that time, we can really promote this as an oral health promotion models actually, in which we will not only save the economy of the country, but we can also let the patients not suffer this consequences in the future as well. This might sound a kind of a bigger shot here, but I'm speaking this based on our particular research study. So it might be that someone else has done a different study who might have a different results, but this is what I'm trying to talk today is based completely on the data, that this is what we find out from the study. So what is really a home takeaway message from this particular presentation is that brain injury and severe periodontitis, they share a complex mix of biological factors. For example, having similar kind of a systemic inflammations, similar altered immune host response. They have a similar environmental factors, for example, smoking habits, alcohol habits, and they also have a similar social influences or the similar social backgrounds. So if person is having a brain injury, a stroke, and a periodontitis, they have a similar background of education level and their economy and their income level actually. So one should consider that periodontitis seems to reflect early in life, which may result from several risk factors. And those risk factors are also clinically identified later in the life as a systemic disorders, which is like stroke. As any other systemic inflammatory conditions such as cardiovascular diseases or cerebrovascular diseases, including stroke, have a similar altered immune response pattern. And it is possible to suggest that periodontitis can be used as an early indicator of various inflammatory disease that share such an intensified immune response, which is similar to stroke and diabetes actually. And other than that, what we really find out, a very interesting finding in this study was that there is a triangular complexity which oral health plays a very, very major role here. So oral health together with the dysphagia and malnutrition, this is a very triangular complexity. So we here really cannot say either the hen came first or the egg came first. So this is a kind of a complex phenomena. They are complementing each other and actually worsening the already situation that is over there. So dysphagia, malnutrition, poor oral health together leads to respiratory infections, finally leading to pneumonia, and this unfortunately ends into the mortality because these patients are very severe patients. In the first 3 months of their brain injury, they suffer from dysphagia, and poor oral health adds a complication on top of that, which leads to the pneumonia. And pneumonia is one of the severity of fatality actually in this patient population. So the clinical implication of this particular study can be that there is a robust association which was found between moderate periodontitis and motor impairment, feeding problems, and dysphagia, which reflects an acute clinical conditions and demands a cross-disciplinary intervention. So you being a dentist, you can contribute to your part, but here we need a multidisciplinary team here. For example, the ENTs and the neurologists also who can look on the dysphagia pictures on a broader level. And then we as a multidisciplinary team can treat this disease of pneumonia, because final aim is to save the life. And that life can be saved by stepwise process, basically, which means maintaining a proper oral hygiene, having a proper dysphagia rehabilitations and all like that. So these all are a very complex phenomena which are intertwined with each other. Periodontal examinations can be an early indicator tool for systemic chronic conditions, as ABI and periodontitis shares a common environmental, social, and biological background. Periodontitis majorly affects aging populations which are prone to pneumonia. Hence, they compromise their rehabilitation plan as well. You can also find this particular studies. This particular studies has already been published, and you can easily find in the PubMed. This particular study was published in brain injury, and also the association between periodontitis and systemic impairments has already been published. And you can easily look on these particular two studies in any of the scientific search engines actually. So that was all from my side, and I would really like to give an acknowledgement specifically to Dr. Paras, who is a very close friend of mine, who gave me this opportunity so that we can come together. I can share my thoughts, my research, and my ideas, and actually come to you. And I would also like to thank Dr. Ravindra, principal of JSS Dental College Dental Hospital, also Dr. Manjunath, and as well as Dr. Kushalappa. So really, thank you to each and everyone, and as well as to Dr. Sheila and Dr. Deepika, who is a professor of periodontitis, periodontal department actually in JSS Dental College. So thank you each and everyone for providing me this opportunity and letting me connect to everyone. And this is my small research group. I'm I'm a part of this big rehabilitation group in which I actually is a group leader of a dysphagia and oral health treatment. But here you can see that we have a various different disciplines, from physiotherapy, from occupational therapists to speech therapy, psychologists, neurologists, ENTs together. So we work as a team together, and then we try to reach to any kind of a conclusions based on our research as well as clinical experience. And in the future also, if you have any doubts, you can easily reach to me, and I've also given my contact details down there with my email address. So feel free to contact me if you have any doubts in the future. And now I would just leave the floor open if you have any doubts or any more suggestions to give forward to me. Thank you.
So thank you, Dr. Mohit. That was very interesting. And we do have a question from Dr. Moria. That is, do all chronic smokers suffer from pneumonia?
Well, that's a very good question, actually, because what I'm trying to say here is that there is a kind of a link in which the chronic smokers has a habit of developing chronic periodontitis. And if you don't keep your oral cavity clean, along with the aging, it can lead to the dysphagia. And consequently, that dysphagia, together with a poor oral health, can lead to pneumonia as well. So this is a kind of a very complex phenomena. It also depends on the aging. As I showed you in some of my slides, actually, that this particular disease affects more of the aging population. So if you're already elderly, there is a motor disability together with you, and you will have a lot of muscle retention problems, which can lead to the pneumonia in the future. I hope I was able to give the right answer, but if not, please you can again have your question framed again.
Yeah. Are there any more questions? Anyone, Doctor? Yeah. There's one more question. I think Dr. Paras, can you just see what is that question?
Yeah, another question is, any biomarkers which are found commonly in periodontitis and pneumonia?
Actually, there has been a few studies on that. We have not been able to do that because of the limited resources, but I know there are few studies that has done that. And then they try to find out possible biomarkers of dysphagia and periodontitis, actually. And why I'm saying dysphagia, because pneumonia is an outcome. So you cannot have any kind of a biomarkers for pneumonia, but you can have a biomarkers for dysphagia, actually. And there are two studies from University of Barcelona, actually, that they try to look on biomarkers, trying to correlate that biomarkers of oral health, which is periodontitis, to dysphagia. And they find out a significant correlation, actually, between both of them.
Okay. The same, one of the audience, a participant, Dr. Moria, who had asked, do all chronic smokers suffer from pneumonia? He's continued his question. Is there any role of aged people for this and the smokers?
Can you repeat one more time, Dr. Paras, please?
Yeah. The same question, do all chronic smokers suffer from pneumonia?
I really can't hear. I'm sorry for that. Can you repeat one more time?
Yeah, he's asked the role of age.
Yeah.
And a correlation between age and chronic smokers.
Yes. Actually, personally, we have not done that kind of analysis, but it would be really interesting to see that if there's a correlation between aging and the chronic smokers, because these all are risk factors which are finally contributing to the some kind of a systemic disorders or even to the pneumonia, actually. So chronic smoker for sure is one of the major risk factors. Aging adds on top of that, because the muscle weakness is there, because these healthy community elderly populations are otherwise healthy, but the muscle flaccidity is happening and the muscle weakness is happening due to the aging phenomena, and chronic smoke on top of that can really worsen the situation, basically. So I would assume that there should be a big correlation between both of them, but I'm not aware if some studies has been done on that area.
Questions anyone would like to ask? Yeah, what I have personally seen is about dysphagia. I've seen two elderly people having problems on dysphagia, and later on leading to CVS problems.
Yeah.
So I do not know if there is any specific connection between the two apart from periodontitis.
Actually, just like 5 years back, dysphagia has been recognized as a geriatric syndrome actually worldwide. So not depending on what particular diseases, for example, like neurological diseases, it has been widely given a title of geriatric syndrome because this is attached with the aging population. Be it a community dwellers, for example, our parents, we usually don't notice when we are sitting on the dining table together, having a food together, you will see them that they are trying to compensate and find a position in which they will do the chin tuck or chin up, and they try to find possibilities that they can swallow easily. And we think this is a very common, normal thing, but this is not normal. This is a situation that has to be looked on carefully, and this has to be given a proper rehabilitation plan, so that the patients in the future does not suffer with the pneumonia. Because what happens is that if you're not maneuvering your hyoid bone properly, your digastric muscles and all other attached muscles to the laryngeal movements, actually, the food might be ending up in the lungs rather than the food pipe actually. So this is a condition which should be observed. And for sure, when you will go back to their home and you will see and sitting with your parents, and you will see them actually, they're trying to compensate and find a strategy actually just to swallow the food properly, safe and secure. But it's not 100% sure that the food is really ending up in the food pipe. It might be reaching to the lungs finally. The only reason is that why don't we see much complications? Then the people would ask, okay, if the food has reached to the lungs, then why don't we find complications? Because most of the patients, the food is also attached with the comorbidities. So if you have a lot of other comorbidities together, this can really aggravate the situation. And as I said, that a lot of elderly population, they try to compensate, they try to find out the maneuver themselves if they cannot eat the food. So this has been a kind of an ignored topic in our society from a long time. But if it is given a proper platform, this can be like really dealt proper way. Because what I'm trying to say is that we always end up finally in the hospital. But there are a lot of preventive measures beforehand, which we take care in the early stages of life, or even before the comorbidity happens. We can really treat those patients pretty much very well while they are very much healthy.
Yeah, that's what I felt when I listened to your talk, because I have faced this in, like I said, in elderly people, and I have observed, like what you said, the way they change their position, their head position and things like that. But yeah, only now that you told, now I am able to understand it was because of this problem. So maybe, I mean, we need to create more awareness in the geriatric population, because most of the time we don't give that much attention to the geriatric population. So yes, I think more awareness programs can be held.
Just to add on top of that, we actually also did a retrospective study on that how the posture, how the head and neck control makes a lot of difference actually. We saw a lot of significant data that if the patient is not sitting straight with a 90-degree angle of their back and the head and neck is not in a control, they have a severe dysphagia issues. So if you have a proper posture, head and neck control, that can also help you a lot actually in order to have a safe deglutition. And this study has also been published last year. So I mean, if you can just look on that as well for the details.
I'm sure many prosthodontists and oral surgery, even I think even conservative, will have opportunities to come up with some research related to this. Even our perio, I think, can think of something in this. And as you said, multidisciplinary team is required to actually do a complete teamwork is required for getting the good results. So I hope everyone will put their heads together.
And actually, this multidisciplinary team looks like a very complex phenomena, but believe me, it's not a big complex phenomena here. For example, you are working in a college, so you have a hospital set up over there. We have all the stream, all the professionals at the same platform. What we all need to do is just make a good collaboration together in order to the welfare of the patients. So we all are working there, but we all are working in one direction. But if we collaborate together, then the things becomes much easier actually to understand.
Okay, I'd like to ask anybody else. Is there, Dr. Paras? Can you?
Yes, two more questions are there. Any recommended postures for dysphagia?
Actually, this is a topic in itself. So I mean, we can really talk in detail, but I think this will be bit of out of the scope of at the moment right now. But I can send you one paper, Dr. Paras, on this one. We have complete a fixed paper on the posture and head and neck control, which is a kind of a prerequisite of a proper swallowing actually. That how the presentation of the food, the smell of the food, and the posture makes a lot of difference. Lot of other different countries criticizes that, okay, we Indians eat by the hand, but there's also a scientific phenomena behind that. The food before we put in the mouth, we have already had that pleasure of the food by touching the food. So this touching the food on the plate sends a sensory and efferent fibers information to the brain. So it makes the brain prepare beforehand, and it stimulates the salivations and all other things. So I think this approach, which I was also trying to put into our hospital, that how, playing with the food, it's not basically playing with the food, but feeding the food. It sends a lot of sensory inputs to your brain actually at the end of the day. So this is basically preparing your mind and your body that, okay, something foreign is going to come in my mouth, and it's basically preparing your amylase protein actually. So the amylase is released much more earlier in the oral cavity. That helps to make a bolus formation and a proper salivation consequently.
Yes, it is like conditioning.
Yeah, exactly.
Yeah. One more question is there. What are the most common causes of dysphagia in the studies conducted? Like maybe they're asking for a summary, like what was the most common single or maybe top causes for dysphagia?
So basically, it depends on the population now. So these populations is a neurological populations. They have suffered from stroke or from a traumatic brain injury. That means the blood clot has been somewhere constricted, and that the brain flow was not enough to the brain. So this is basically a brain lesion, and because of the brain lesion, that particular swallowing area is affected much more faster in a stroke populations. So whenever you will see stroke, 50 to 74% of the population of the stroke actually have a brain lesion on the swallowing area of the brain. So in which we actually cannot do anything more in that, because this is a spontaneous recovery. But what we can do in this period is that we can try to avoid swallowing in this particular time by different maneuvers and all like that. But in these patients, the neurological populations patients, it's more about the brain lesion, and the brain lesions has a spontaneous recovery, but it takes 3 to 4 months actually. So that's one condition. The second condition is head and neck cancer patients. In head and neck cancer patients, when there is a lot of surgical excision of a lot of muscle parts of the body, so in that way there's a different phenomena. So that also is a bigger population that is suffering from swallowing disorders. And other than that, 44 to 52% of the community dwellers actually, people who are aged, who are living within the society among ourselves, but more than 65 plus years of age, that 40 to 52% of the population is suffering from dysphagia. So there is a broad range of people actually suffering from dysphagia. So dysphagia itself is a disorder touching different kind of morbidities here.
Yeah, thank you for that. One more question is there. Shall I continue?
Yeah, please go ahead.
Yeah. The question is, what is the prevalence of dysphagia in periodontitis patients?
Well, this is a very good question actually, but what we find out in our studies, that which I showed you one of the slide, is that there were 90 participants in the study, and out of that 50% had a dysphagia, and 74% of the populations had severe periodontitis. So what we find out that every dysphagic patient is having some form of periodontitis at least. So there was not only severe but also moderate periodontitis. But it would be a little bit premature to say that it's only dysphagic population that is associated with the periodontal population, because there were a lot of non-dysphagic population also they had a significant correlation with the periodontitis.
Thank you. I have one personal question. Like
Yeah.
we see a lot of kids, they have enlarged adenoids. So that also I think contributes to difficulty in chewing, maybe during the transient phase of childhood. That is a treatable condition, and I see that some parents are they don't agree for any sort of removal of the adenoids or the. So what is your opinion regarding that? Pediatrics.
Yeah, I mean, yeah, what I would try to say in this direction is that if there is a requirement of surgical excision, as per the doctor's recommendation, we should really go forward with that. But on my personal experience, I have never worked with a pediatric patient, so it would be like really out of my scope to give a definite answer. I can only give the answers based on the opinions over here.
Yeah, and one thing I want to know, like, is there would be a significant role of saliva in dysphagia? Because I see so many geriatric patients, probably who are reporting to our hospital, they have a lot of root caries, and when we examine, they have dry saliva. There is the dry mouth, and dry mouth is there. So I think that saliva has got a major role in dysphagia.
I would completely agree with you, and I think this is the much more topic which has to be actually explored. What we find out that if you have a aging population, so there is already a less flow of saliva, and then the xerostomia is over there, and then you cannot eat the food. When you don't eat the food, there is already less salivation going on in the body, and that causes a lot of dehydration, which leads to not only caries but also increasing the oral pathogens actually. So these all are very complicated phenomena which are related to each other actually. But on the other hand, we have a lot of patients who has a drooling of saliva. The reason is that you cannot put the food in the mouth because of the dysphagia issues. They have a tracheostomy tube as well together. So there is a lot of saliva production happening, and then the saliva is completely kind of a drooling. And this is a very common condition which is happening in the Parkinson patients and the cerebral palsy patients actually. They cannot have a proper lip closure. In cerebral palsy patients, 80% of the palsy patients have a problem of a lip closure, because if you can't close your lips, then the saliva keeps on drooling all the time. And when you can't eat the food, this young population, because cerebral palsy is much more affected in the young populations, they have their active lifestyle, so the saliva is produced much more heavily, and if you can't swallow, it actually kinds of a drool. So you know, it's a kind of a double-edged sword. We have a lot of patients with the xerostomia, so what we do is that we provide a lot of moisturizers to them. So there are a lot of other kind of activities which we aid as a complement to them in order to maintain the hydration of the mouth. Because if you don't maintain the hydration, then there is a more chances of having a caries. And we as a dentist just think about it, okay, this is about caries. No, it's not about caries. We are actually burdening the whole process here, which is finally leading to the pneumonia.
I think this is all. I would like to thank Dr. Sheila for the interesting session and also the speaker for the question and answers. I would like to compliment Dr. Bella Dev, have complimented that's a very good presentation. And one anonymous attendee also has given the compliment. I just want to share with the speaker and the audience.
Thank you.
I would now like to request Dr. Deepika to give the concluding remarks and propose the vote of thanks.
Hello. It's fallen upon me to give the vote of thanks. I express my heartfelt gratitude to JSS Academy of Higher Education and Research and our Honorable Registrar, Dr. B. Manjunatha, for permitting us to hold this webinar. We are also thankful to our beloved principal, Dr. Ravindra, for facilitating it. And I sincerely thank our speaker, Dr. Mohit Kothari, for taking us through this unexplored territory. Thank you, Dr. Mohit, for this novel webinar. And I also do thank the attendees, without whom this wouldn't be a success. Thank you very much. Thanks.
Thank you. Thank you to everyone, each and everyone.
Thank you, ma'am, for the vote of thanks. So now we conclude the webinar on this on behalf of JSS Dental College and JSS Academy of Higher Education Research. I once again thank Dr. Mohit Kothari for accepting our invitation for the webinar, and also thank all the participants for attending the webinar. I hope this webinar would be useful and for many collaborations and research. A recording of this webinar will be available soon on the YouTube of JSS Academy of Higher Education Research. Thank you all and stay safe.
Take care. Bye-bye.
Thank you.
Bye. Thank you.
Thank you.